Hello, hi, my name's Charlotte Cliffe. I'm a general adult registrar and currently working as a BRC clinical preparatory training fellowship down at the Maudsley. Let me just share my slides, if you can see them. They come up?
Yep.
Okay.
Excellent.
Great. So I'm going to be talking about a study we looked at where we were evaluating the performance of a previously developed natural language processing tool looking for suicidal ideation in a clinical sample of patients who have a diagnosis of an eating disorder. So as we've heard sort of today, electronic health records are increasingly being used in hospital care systems, which allows us to develop these natural language processing tools to derive information about symptoms from the free text, which is incredibly helpful for us when we're conducting research within this area, as suicidal ideation is routinely assessed in all our records. Suicide is at increased risk in people who are diagnosed with eating disorders. And we know that people who report suicidal ideation are associated with an increased risk of suicide. Therefore, there is a need for us to understand what factors might be associated with the risk of suicidal ideation. So our aims were to validate a previously developed NLP tool within this cohort of patients, and then determine the prevalence of suicidal ideation and understand any risk factors, demographics and comorbidities that might increase the risk of those reporting suicidal ideation. So we took anyone who had a diagnosis of an eating disorder within SLAM's NHS Trust from the years of 2007 to 2019. And we extracted their records using the CRIS database, which we've heard about earlier today. And then we sampled a random selection of documents, and we did this by breaking the document length down into quartiles and then selecting a random selection from the first and third to kind of eliminate any really short and really long documents. And two researchers manually annotated a selection of documents to develop a gold standard, which we could then compare with the previously developed NLP tool's output to look at precision recall and the F1 score to see how well it was performing. So the previously developed tool is a rule-based tool, and how it looks is we had mentions of positive mentions for suicidality. So for an example, X reported thoughts to end her life. Those who would be non-suicidal, which we reported as negative for suicide. So for example, X denied suicidal thoughts. Those where it was uncertain, so for an example, X took an overdose, but it wasn't clear whether or not this was with any suicidal intent or not. And then non-relevant. So for example, X's friend was suicidal. And although the tool was developed on both mention and document levels, for the purpose of this project, we looked purely at document level mentions as we were looking at whether or not a patient had at any point reported they were suicidal. So whether or not there was one mention in a document was enough for us to then report that this patient had reported suicidality. So we had two of us coding, myself, a psychiatrist, and a BSc student. They had 400 documents, I had 300 documents, and they were broken down into 200 with that had been flagged up as positive mentions for suicidality and 200 that hadn't. And then we calculated an inter-rater agreement between these, and then any disagreements we discussed in person so that we developed a gold standard group of documents in relation to the rules for the NLP tool. So we coded them as suicidal, negative for suicide, so non-suicidal, uncertain, or not relevant. And then we compared these to the NLP tool's output for the same group of documents. And then once we'd determined how well the tool was performing, we would then use CRIS to extract demographics and clinical features for patients within the eating disorder cohort, so we could compare those who had positive mentions of being suicidal and those who were non-suicidal. So in total, we had 7,188 patients with a diagnosis of eating disorders, and 6,972 of these had at least one document. And in total, that was over 1 million documents to analyse. There were 4,528 patients who had at least one mention of being suicidal, which was over 60% of the patients in our cohort who had a diagnosis of an eating disorder. So then we had the randomly selected documents, and the results demonstrated that positive mentions and non-relevant mentions had an inter-rater reliability agreement of over 0.8. So you can see here how the tool performed. So positive mentions for suicidality and non-relevant documents, the tool performed very well. Non-suicidal documents, however, particularly in precision, the tool did not perform as well. It's still relatively reasonable, but not as well as for the other two. With our study, we were looking at one previous mention of suicidality, therefore this was kind of unlikely to affect any of our results. So when we look at the clinical results, you can see that there are various factors associated in terms of demographics with reported suicidality. Being married was actually protective, white ethnicity increased the risk, and those who had a diagnosis of anorexia were significantly more likely to report being suicidal than other diagnoses. And I guess as not unexpected, those who had a comorbidity, particularly a personality disorder diagnosis or bipolar diagnosis or substance misuse, were also significantly more likely to have reported suicidality at some point. So the NLP tool performed well for positive and non-relevant mentions, and we were able to identify those who were at risk of reported suicide ideation. However, it did not perform as well for non-suicidal mentions, and this is likely due to errors in the linguistic preprocessing needed to identify negation of sentences. But as I said, it's unlikely to impact the clinical results. So strengths of the study was a long time for follow-up, so we had a relatively large cohort. As previously talked about, these are routinely collected and unlikely. This reduces the risk of reporting bias. However, this relies on clinician reporting, and there was also no consideration of temporality with suicidal ideation and an eating disorder diagnosis. There's also, just to mention, the changing of diagnostic codes as well between the years of 2000 and 2020. So we broke the diagnoses down into anorexia, bulimia nervosa, and then otherwise unspecified eating disorder diagnosis to kind of eliminate the difficulties with the changing codes. So in terms of the impact of this study, so it highlights the importance of risk assessment, screening in patients who have a diagnosis of an eating disorder, as over 60% of those did report suicidal ideation at some point. It also demonstrates the usefulness, again, of the clinical records, particularly Chris, for conducting research within this area, and also allows us to think about the potential of these tools in future risk prediction. So kind of key messages, as we've talked about, electronic health records are a very important source of research data. The NLP tool detects relevant suicidal thoughts pretty accurately, but the non-suicidal documents less accurately. Suicidality is common in people who are diagnosed with eating disorders, and comorbidity is a key risk factor for someone who has a diagnosis of an eating disorder for reporting suicidal ideation. Just to acknowledge the authors in the study, as this was part of a larger study, and thank you to the other members of the CRIS team for their support. Thank you for listening. Any questions?
Charlotte, thank you very much indeed. Brilliant presentation and wonderful timekeeping.